Fran Brooks, pain person.
There's not hardly a minute that goes by that I don't feel some sort of pain somewhere. It strikes without warning. The real severe pain does. I have constant pain all the time. My back hurts, my shoulders hurt, my leg hurts. I call them my labor contractions. They are so sharp and so sudden that it just takes my breath away.
Here are cervical spine films.
John Lozier runs the pain clinic at the University of Washington. The unit accepts 5 new patients with long-term chronic pain every week.
The technique is to work both on the patient's body and on the patient's mind, to condition it to minimize the impact of pain. Fran Brooks has been referred to him for treatment.
Joints well preserved, and I don't see any abnormality in the bone at all, no soft tissue masses. I really don't think these contribute in any way to our understanding of her pain.
One of the things that
Lozier and psychologist Wilbert Fordyce work with patients who continue to hurt even after they've healed. Patients whose pain researchers are struggling to understand.
You're going to have to devise some as yet unknown mechanism for explaining why an injury would continue to hurt years later, when all the evidence we have is that the body tissues heal within a few weeks.
Fran has come to Seattle for a 3-week stay at the clinic to try to alleviate her pain.
Patients who come to a program like this clearly are suffering. People will ask, is the pain real? That's a nonsense question. Of course the pain is real. The proper question is, why is the person suffering? She's an anxious person. Anxious, uncomfortable, easily upset, thin-skinned, I think would be another way of putting it. A number of indications would suggest to me that indeed she looks like someone who would be at high risk to confound or mix up suffering, more generalized suffering, anxiety, depression, fear, things of that sort, with pain.
As fast as you can. Walk on down and back. On your mark. Get set. Go.
Day 1, the speed walking test, which will measure Fran's progress during the 3 weeks.
Keep on going. Just as quick as you can.
Pain from an injury becomes chronic, usually because people overprotect themselves. They rest too much, they guard too much, they wait too long for healing. We call it disuse.
Oh, now.
Good.
The second reason why pain may become chronic is because once the person begins to express the suffering, people around them overprotect them and encourage them to take it easy, so on.
All right. 50.6.
If you're moving freely, then other people can hardly behave toward you as if you were very sick. And it makes it easier then to avoid having other people reinforce sick behaviors or pain behaviors.
Arms overhead. Take a nice deep breath in and just reach on up. And exhale and relax on down.
This combination of physical and behavioral therapy lies at the core of the treatment. Both are directed toward changing the patient's obsession with pain, a state that's uniquely human.
And let's switch directions, please.
There is no animal model for this kind of a problem. I mean, can you imagine what would happen to a deer that said, well, I just can't go out and forage for my living, and I'm going to lie down here and let the world take care of me. If he didn't starve to death, the wolves would eat him overnight. And it's only in an industrialized society such as ours where human beings can survive saying, I'm unable to work and I'm unable to take care of myself.
So then after 2 or 3 weeks, and it didn't get better, then what was that like?
Frightening.
Week 2, the midpoint of the treatment.
Yes. Yes.
Got depressed.
The team works to get the patients to confront the influence pain has had over their lives.
And it seemed like then I hurt more and was more snappy at my children.
Okay. But when Fran was worried, it wasn't that her back or her shoulder was hurting more, but because she was worried, she suffered more. That's
true.
Yeah. What that, of course, illustrates is that our minds indeed will influence how we feel, how much we suffer, just on the basis of what it expects or anticipates.
Week 3, the treatment continues.
Sometimes it happens when people go through our program that at the end of the program or even before they say, hey, no more pain. But that's rare. But almost without exception, people at the end of the program will say, I'm able to do a lot more.
And let's go down.
Well, I touched it.
All right, good.
Hey, that's right.
And bend your knees and come on up. In fact, we've got a group of overachievers.
Did you see that fish jump? Hello.
Graduation day.
I'm ashamed.
On your mark.
The last speed walk.
Go. All right.
Flat. That's a workout. That's a workout.
Isn't this a neat lady?
Yeah.
L5S1.
Recently, there has been an increase in the use of opiates or narcotics to treat chronic pain. Such therapy raises several issues and questions about potential risks.
Opiates are probably the best medication we have for acute pain, for pain due to an injury, a broken leg, surgical procedures, and opiates are standardly used in that setting. Opiates can also be used for chronic pain. We see a lot of opiate usage in the management of pain due to cancer, and there are some patients with pains due to nerve injuries or musculoskeletal conditions for whom opiates are a reasonable long-term management scheme. But the use of opiates over long time spans requires special considerations because of some of the pharmacologic aspects of opiates as drugs in human use. If you give an opiate over time, most people will develop what is known as tolerance. Tolerance means it takes more drug to get the same effect. Tolerance is virtually universal in long-term opiate usage. Tolerance is not a real problem because the drugs are cheap, and if you need to give more drug to get the same effect, so what? The second phenomenon you have to talk about is called habituation. And if people are habituated to the drug, it means that they're tolerant and that if they suddenly stop the drug, they will undergo a set of psychological and physical reactions that are often very unpleasant, that can in fact be significant health hazards due to the sudden cessation of the drug. That, too, is not really a problem because there's no need to suddenly stop the drug. If you wanted to get the patient off the drug, you could always taper it down. The third phenomenon is addiction. Addiction means the patient has a psychological and physical craving for the drug that is so profound that they are willing to risk their lives, their employment, their families, put themselves in jeopardy in the pursuit of the drug. Addiction is an illness very similar to alcohol addiction or any other drug addiction. It's very difficult to treat. And all of the evidence we have says it virtually never is related to the use of opiates for
for the purpose of relieving pain. It's a great distinction to be made between people who take opiates for pain relief and people who take opiates for other reasons. People who take opiates for pain relief are very unlikely to become addicted. People who take opiates for other reasons are addicts and are going to have a very much more difficult time getting off the medications. What they get from medicines is totally different. Most people, when you give them narcotics, say, the pain relief is great, but I don't like what this medicine does to my brains. Narcotic addicts will tell you that the medicine makes them feel good. It gives them good feelings. Most people don't say that about narcotics. So I think there are profound differences. There's something different about the brain of an addict, and it is that difference that leads them to become addicted to medicines. The average patient doesn't have that risk. I think in the last 15 or 20 years it has become obvious that there is a small number of patients with chronic pain, not due to cancer, due to nerve injury or other kinds of problems, who in fact can be adequately managed with long-term opiate use. The issue is adequacy of management, not risk of addiction. And what I mean by that is, if you're going to treat chronic disease, you must recognize that something above and beyond the patient's report of symptoms is relevant to outcome. So, of course, I'm interested in what the guy says about his pain, but I also want to know, is he doing anything that he couldn't do before? Like, is he going back to work? Like, does he have the ability to exercise? Like, is he not consuming health care anymore for his pain problem? And if you apply some reasonable set of outcomes measures to patients with chronic pain, you realize that there are a significant number of people who tell you that the narcotic or the opiate makes them feel better, but they don't do anything any different. They remain just as disabled, just as much health care consumption. And the issue then is, are opiates the best treatment you have available for this patient? Because a program of rehabilitation to get the patient back into gainful employment, normal physical and psychological activities may be much more effective than opiates. But the problem is simply not the risk of addiction. The new developments in pain management are not going to be built upon using opiates more aggressively or assertively, but are going to be based upon new medications that act in different places in the nervous system and in the body tissues, so that I predict we will have combination drug treatments that may still involve opiates because they are effective in some ways, but we're going to do a better job with other kinds of medications that are going to add to the treatment resources that we have available.